Many travelers dream of experiencing the beauty of Tanzania, from its stunning national parks to vibrant cultural sites. Yet the costs often seem overwhelming. But with Visit Tanzania for Less, exploring this East African gem on a budget is not only possible, but incredibly rewarding. Whether you're a solo backpacker, a volunteer, or just a budget-conscious traveler, we provide valuable insights and resources to make your journey unforgettable without breaking the bank. Book your trip now with just a $300 deposit and flexible monthly payments until your travel date. For more travel inspiration and tips, follow us on Instagram or visit us at visittanzaniaforless.com. Visit Tanzania for Less, your dream adventure within reach.
What's something people don't know about community impact? A simple donation can transport kids to the heart of Ghana, opening a world of possibilities. Since 2017, thanks to 103.7, The Beat and community supporters like you, dozens of kids have embarked on a journey of a lifetime to Ghana. This isn't just any trip. It's filled with learning, adventure, and joy. These kids are diving into a culture rich in tradition. They're learning about the world beyond their textbooks. This program educates and connects communities, building bridges. Your support can light up a child's life. It's an exploration of potential and a celebration of new friendships. Donate today at kidsfreetriptoafrica.com. Every donation matters. Please donate today at kidsfreetriptoafrica.com. Thank you.
Good afternoon. I am Melvin Burns. I want to welcome you to Torn in Two. I'm usually not the one that introduces the show, but my partner in crime, Brother Gregory T, is not here today, so they're trusting me to steer the ship ashore solo today. So I'm here in the studio. I want to welcome you to the show if you've not heard us before. It's called Torn in Two, but we actually, we're news and information. So let me first do a couple things. Let me tell you about the weather. Today, sun is starting to come out. We have a low of 57, high of 68. Tomorrow, 30% chance of rain, low 55, high 69. Sunday through next Thursday, we have the sun out, low 55, high 69. Monday, low 49, high 65. Tuesday, still sunny, low 46, high of 68. Things start to warm up next Wednesday, a low 58, high of 73. And next Thursday, a low of 60 and a high of 76. So hope that you'll get a chance to get out and enjoy some of this nice June weather. Again, well, thank you so much for joining the show. Again, you can listen to us on your radio, 103.7 The Beat. You can catch us on Facebook Live, Torn in Two. And if you have the emoji app, as Greg would always tell you to download that app on your phone, you can catch us on a number of platforms as well. I'm excited to bring our guest to the microphone today. His name is Dr. Kevin Foley, and he is a board-certified internal medicine specialist. And today we're going to be talking about memory loss, Alzheimer's, and diseases related to the area. So would you join me and welcome into the microphone our guest for today, Dr. Kevin Foley.
Hello, and thank you for having me on the program today.
You're more than welcome. Good afternoon to you, Dr. Foley, and thank you for joining us on Torn in Two. Why don't we start off? Why don't you introduce yourself and tell folks a little bit about yourself?
Mhm. My name's Kevin Foley. I'm a professor in the Department of Family and Community Medicine in the College of Osteopathic Medicine at Michigan State University. I've been there for the last 12 years, but I've also been the medical director of the Alzheimer's disease and memory disorders program here at Trinity Health West Michigan in Grand Rapids for the last 21 years. And I've devoted my clinical career for the last 15 years to evaluating adults who have memory loss and also treating them. And about a third of the population of adults that I see have some form of dementia, most of them Alzheimer's disease.
Okay, thank you. Let's start broad and then we'll kind of narrow down. I'm 62. I'll be 62 next week. You know, uh, trying to recall something, you do the finger snap and try to think of a family member's name that you always know and it doesn't come to you. Um, Tell us what are the early stages when we should get concerned about loss of memory.
Yeah, normal is a wide range. If you think about it, everybody's
Okay,
brain works differently. Everybody
sure.
uses their brain differently. Everyone has different experiences, levels of education. So, from my perspective, it can sometimes be difficult to listen to a concern and determine whether or not that still is within the bounds of normal or abnormal. But what's most important for me to hear is to get a sense of what a person's background or baseline is. If
Okay,
they've always been a little bit forgetful and remain a little bit forgetful, then that's probably not a warning sign. But if
okay,
they've had a very good memory and then begin to exhibit changes, particularly in short term memory, that they or other people notice, that really needs to be evaluated.
okay. So, what are some of the first things people begin to notice where they get concerned?
Yeah, I can tell you that by far and large, 99% of the time, the complaints that I hear are in regard to short term memory. Long term memory tends to be very resilient.
Okay,
It is almost rarely impacted by diseases like Alzheimer's disease early on. But if you think about it, it's really the short term memory that gets through your day. You keep it
okay,
in mind of the things that you're going to do.
hmm,
So if you trip up, if you have difficulty with getting things done, it's more than likely going to be as a result of impairment in short term memory. So having difficulty remembering recent events and conversations, remembering things that you have to do, things that you might need to pick up at the store, plans, etc. It could be any number of symptoms that are related to short-term memory, but it's almost always a complaint regarding the impact of short-term memory on getting things done throughout the day.
okay. So I go to my regular doctor and I say, doc, doc, I'm starting to get concerned in through the day. I think I'm gonna do certain things I forget by the end of the day, those kind of things.
Mhm.
How do I go from uh, talking to my regular doctor to a specialist such as yourself?
Yeah, I really rely very heavily on primary care physicians to vet the concern and to learn more about what the significance of the complaint is, and even to start doing some preliminary testing. So,
Okay.
most primary care physicians should be able to do that in their offices. It's a
Okay.
matter of asking more or less, when did it start? How has it changed over time? How is it impacting your day to day routine? And also looking at a person's health and their state of wellness. Do they feel unwell? Do they feel well? Are they sleeping fitfully? Are they not? Do they have any symptoms that might suggest sleep apnea, which is a reversible cause of memory loss? Do they have any abnormal blood tests? Is their mood good or not? So it's helpful to have all of these issues addressed first by the primary care physician before considering a referral to a specialist like myself.
Okay. That's good. Having somebody who does a sleep apnea, I'm familiar with that as well.
It's
Yeah.
very common, very common.
Yeah. So we throw around terms, memory loss, dementia, those kind of things. Of course, they mean something different to professionals such as yourself. So let help us with some of the terminology. Uh, Dementia, Alzheimer's, memory loss. Help us with what those things
Yeah.
mean.
And I expected that question because it's the most common one that I get, and I can well understand because the terms seem to be used interchangeably in
Yes.
various ways. So I'll try and define them as simply as possible. Normal is normal. And
Okay.
normal is applied to the individual. Again, as I said before, someone might be very forgetful all their lives, but that's normal
Hmm.
for them. The first stage of memory loss, so to speak, is what we call mild cognitive impairment. That is actually a medical term that can be used to diagnose somebody who has more than normal memory loss that is seen by that individual and by others, but it does not impact their ability to get through their day successfully.
Okay.
They can take care of all their personal responsibilities, whatever they may be, manage their finances, shop, make meals, get in a car and go where they have to go, use communication devices, etc., all by themselves. And
Okay.
I could talk about the relevance of that in a moment. On the
Okay.
other hand, when memory continues to decline, such that a person really can't function independently and relies on someone else to help them to do those things that they could once do all on their own. And again, that could be for any of the areas that I talked about: finances, shopping, cooking, transportation.
Okay.
That might suggest that their diagnosis is in fact dementia. So
Okay.
dementia and mild cognitive impairment really describe outcomes. If
Okay.
you can do things for yourself or you can't, but neither of those terms describe what the underlying cause of the memory loss may be that qualifies them for those diagnoses.
Okay.
So the Alzheimer's disease is a cause of memory loss and can lead to both mild cognitive impairment and dementia.
Okay.
So the words should be used in a way that describes the outcome and the cause. So we say Alzheimer's dementia to describe the cause of the memory loss and the outcome. You can
Okay.
have Alzheimer's disease that causes mild cognitive impairment, and believe it or not, you can actually have asymptomatic Alzheimer's disease as well.
Okay.
So if somebody says I have dementia, I know
Mm-hmm.
that they are dependent and need to rely on somebody else to help them. But my next question is, well, has anybody tried to determine what the cause of the dementia is?
Okay.
And it's important to know because each of these conditions that cause either mild cognitive impairment or dementia have different prognoses, and sometimes they have different treatment options as well.
Okay. And so this, again, this name we're afraid to say Alzheimer's. What is Alzheimer's exactly?
Yeah, it's a term that it strikes fear into many people's hearts, and I can well understand why. In 21 years of doing this work and seeing thousands of patients, I get very close to many of my patients, and I believe that I understand what they are feeling and how they view their futures.
Mm-hmm.
But I can again talk about this too. There are some new treatment options that are
Yes.
coming that will provide more hope. Alzheimer's is a disease. It has
Okay.
nothing to do with normal aging. It is a syndrome that is seen worldwide. There's not a country on the earth that does not have Alzheimer's disease. We're still trying to understand why certain people get Alzheimer's disease, what the risk factors are, but suffice it to say, it's not something to be expected as we get older.
Okay.
And because of the misperception that memory loss is part of normal aging, which it is not, oftentimes the early symptoms are dismissed.
Mm.
But as the disease begins to take hold in the brain, it starts off a cascade of changes, of pathological changes that lead to worsening in memory. And over time, the disease does spread throughout the entire brain. Very slowly over a course of years, but it does spread.
Okay. So, again, you talk about Alzheimer's not necessarily being an old people disease, if I can use that terminology. Because I think, I'm a day I remember when we started using that term Alzheimer's. So, what age is there a specific age that we start to be more concerned or look for those things?
Yeah, yeah, it still is considered a disease of older adults by
Mm-hmm.
far and large.
Mm-hmm.
The average age of onset is between 72 and 74.
Okay.
However, there is a form of Alzheimer's disease that affects younger adults or middle-aged adults. It's referred to as early onset, and that's by definition symptoms that begin before the age of 65.
Okay.
And it progresses in the same way as it would in an older adult. In the state of Michigan, the current estimates are that we have somewhere between 20,000 to 25,000 adults who have early onset Alzheimer's disease.
Okay. Okay. So you started to talk about some of the treatments that are taking place for Alzheimer's.
Yeah, the research is moving at a fast clip, let me tell you,
Okay.
and that's good news.
Mm-hmm.
I've seen more developments in the last 10 years than I've seen in the last 40.
Okay.
For many, many years, we've relied on the use of medications, oral medications, to slow down the rate of further progression of symptoms. those are still available and they have a modest effect. They only treat the symptoms, though, and not the underlying disease. So
Okay.
the disease will progress, and ultimately the medications will stop losing their effect.
Okay.
Within the past year to year and a half, we've had the approval of a new class of medications that are considered to be disease modifying drugs. Rather than
Okay.
treat the symptoms, they treat the underlying pathological changes that are occurring in the brain. And then, thusly, they lessen or slow down the rate of symptoms associated with the disease. So
Okay.
that's very exciting. This is the first
Yeah.
time we've had this breakthrough. The research is still ongoing. The early reports from the studies that have been conducted suggest that the drugs have a modest effect,
Okay.
but nonetheless, this is a real breakthrough, and we're hoping that further research will show that the effect is even more than what might be suggested from the early studies that have been conducted thus far.
Okay.
The disease modifying drugs have to be given as an infusion, which is different than a pill. They also have to be given over a long period of time. For the one medication that's currently improved, the regimen requires that patients get infusions every 2 weeks for 18 months.
Okay.
And we'll see whether or not that protocol is continued over time. It may be that less treatment will lead to the same outcomes. We're still in the phase of understanding how these medications work, but they're very effective at removing one of the main pathological changes that occurs in the brain of patients who have Alzheimer's disease.
Okay. Why an infusion, Dr. Foley?
Yeah, it's the way that our bodies are constructed. We all
Hmm.
have something called a blood-brain barrier. It's something that keeps bad things out of our brains
Okay.
and lets good things in. But
Okay.
that blood-brain barrier also prevents medications from
Oh.
sometimes crossing from the blood into the brain, and that's a problem with oral medications.
Oh. Okay.
Yeah, with the infusions, the likelihood is greater that the drug will actually get into the brain as it should.
I see. Okay. Dr. Foley, if we could back up to this sort of broad area of memory loss and, you know, kind of deal with some of the things we've heard, we don't, with things we've heard, we don't find out they may or may not be sound. Are there foods that we can eat that help our memory loss?
Uh, well, that it depends on who you ask.
Okay. I'm up at 3 o'clock at night and I see them advertising all kind of stuff to help your memory and
There are, as far as specific diets, dietary research has been going on for years and years and years, and
hmm.
there are many authorities who do recommend specific diets, specifically the Mediterranean diet
Hmm.
or what's called the MIND diet,
Okay.
to help with maintaining brain health and possibly delaying the onset or slowing down the progression of memory loss symptoms.
Okay.
Those diets can be a bit challenging to follow. They require special ingredients and more prep time. Uh, I would support anyone who would want to go down that road and try and change their diet, but I'm still not absolutely convinced that doing so will keep them out of trouble.
Okay.
Exercise is a good thing. There is some evidence that regularly exercising will help to stave off memory loss and may slow down progression of symptoms. That work is still going on. Brain games, brain exercises, there's varied opinions about the efficacy of those strategies. And what we don't know is what is the very best exercise that you could do for your brain that will improve your day-to-day memory.
Oh, okay.
Everybody says do crossword puzzles. I'm not convinced that crossword puzzles will help you remember where you put your keys. I really don't. But that work
Okay.
is also going on. Now, one of the
Okay.
questions I
Interesting.
often get is, what about these over-the-counter supplements you hear about?
Exactly.
Research is just not convincing that they will make any difference. And also, if you listen very carefully to the advertisements, I believe for all of them, the tagline is that they are meant to be given to people who have what's called memory loss due to normal aging,
Okay.
not
That
Alzheimer's disease or
gotcha.
mild cognitive impairment. So
Uh-huh.
you got to be careful. Listen to all of the words in the advertisement before you go to the store to buy something.
Yeah. Well, you touched on a lot of those I was going to ask about. I remember my mom getting in her 80s and, she was, you know, adamant about doing her crossword puzzles every day and the word searches. It's like, hey, if you I didn't know I do any research, but she felt like they helped. I didn't question her, but I recall
Yeah.
her doing those.
I don't question anybody either. If they want to do that and it's enjoyable, then by all means do so. But
Okay.
as I said, it's probably not going to help you remember where your keys are.
Like you say, I'll get them up at 2 or 3 in the morning. I'll see the supplements, like you say, and all these items, and even you go into some of those stores where they have vitamins, you'll see the brain loss items to take, and um, I think again, if you look at the fine print on there, these haven't been tested, those kind of things to
Exactly.
sure. Yeah, folks, this is Torn in Two. We're on with Dr. Kevin Foley, and we're talking about memory loss, Alzheimer's, dementia. If you're some of our young listeners, maybe you're curious, or you've maybe start to see symptoms in some of your older relatives. If you're some of our older listeners like me, it's a topic you might be interested in. Maybe you've noticed you can't recall a few things like you used to. What do they say? You walk in the room and forget why you walked in there. So maybe you're starting to see some of those things that concern. Well, today's a chance to kind of listen, learn a little bit more about some of these areas of memory loss, and get a little more informed. And perhaps there's some things you need to pay a little attention to. So, Dr. Foley, you talked about relying a lot on the screening of by our primary care physician. Can you tell us a little bit about what that's like?
Yeah, all primary care physicians approach these screenings differently. In
Okay.
my view, what would be important, in addition to getting the story, as I'd alluded to before, is
Mm-hmm.
do some type of a brief memory test just to
Okay.
get a rough idea if
Mm-hmm.
there are significant findings or not. And also to ask questions about some of those conditions that I had alluded to that might be a cause of memory loss. And first and foremost is to ask questions about sleep apnea. Sleep
Okay.
apnea is incredibly common in this country. 1 in 4 men have sleep apnea, 1 in 10 women, and
Mm-hmm.
it definitely can cause changes in short-term memory.
Okay.
So a referral to a sleep center to have a sleep study done would be appropriate for anyone who has risk factors or who has positive screening tests for sleep apnea. So
Mm-hmm.
that definitely needs to get looked into prior to a referral to a specialist like myself.
Okay.
Asking questions about sleep in general. Does somebody have restorative sleep, or do they stay up all night? Insomnia can affect your memory. Both of those are treatable. Both are very
Mm-hmm.
common. And the likelihood is that with successful treatment, that if your memory loss is due to sleep apnea or insomnia, that your memory will get better. So you
Okay.
shouldn't have to wait to get in to see me to tell you what something like that might be offered through a primary care office.
Okay.
And then looking at medications, there are certain medications that can impact your memory
Okay.
and mood. People who are very depressed,
Mm-hmm.
they often complain of memory loss, and all primary care physicians should be well equipped to screen for depression and to treat it.
Okay. I think we have a few questions coming in. Here's a question. It says, "Is dance considered an exercise that helps with memory loss more than other types of exercise?"
I'm pleasantly surprised to see that question. I don't think that various types of exercises have been viewed in terms of their relative effectiveness.
Okay.
I think that most exercise researchers would recommend that aerobic exercise would be better than non-aerobic. I think that in
Okay.
certain circumstances, dancing can be aerobic. No question
Okay.
about that. I came across a research study that was done, must have been about 15 years ago, that suggested that ballroom dancing could lessen the risk of memory loss over time.
Oh,
But I have not seen other similar studies suggesting that other types of dance might be as equally as effective. So I,
uh,
I,
that's
I
that's
guess based on
interesting.
my limited understanding of research is, yeah, it might. And
That's
it's
interesting.
fun.
Okay. Yeah. And I think we have another question or comment here. Let's see. Um, Maybe not. Dr. Foley, you talked about some of the um, recent medications. What is some of the research that's being done now in this area?
Yeah, with the development of the new medications that target one of the main pathological changes in the brain, the formation
Hmm.
of amyloid protein,
Okay.
many researchers are now of the opinion that that is probably the target that needs to be hit and probably is the reason why people lose their memory over
Mm,
time because of the accumulation of this protein. So there
okay.
is a great deal of more interest and research effort in looking at treatments for amyloid and the timing of the treatments based on when amyloid forms to see if we may even at some point in the future have a preventative treatment that we
Okay.
could give before this amyloid begins to form and
Okay.
just stave off memory loss altogether. But there are several other compounds that don't act on amyloid that are also being investigated. There's so many different changes that occur in the brain of an individual with Alzheimer's disease. There are many potential targets that could be looked at in terms of drug development, but most of the emphasis right now is on drugs that affect amyloid.
Okay. Now, I remember they were telling everybody to throw away their aluminum pots and pans. Is that still a thing?
No, it's yeah, no. I would say that there's a few holdouts there, but no,
Okay.
yeah, and there was some studies that were done many, it must have been the 70s or 80s that looked at the rates of development of Alzheimer's disease in bauxite miners. Bauxite is the
Oh.
ore that is made
Hmm.
into aluminum.
Okay.
They're around it all the time, probably inhale it, and they had no higher risk than anyone else. So no,
Okay.
that's been debunked. I
Okay.
heard this. I haven't actually gone back and looked at this specifically, but I have heard from other colleagues that the reason that aluminum was pinpointed as a possible cause of Alzheimer's disease is that if you look with special microscopes at brain tissue that has amyloid in it, the people who have Alzheimer's disease, sometimes you can see aluminum particles that are within the amyloid plaque itself.
Hmm.
So the thinking is, well, the aluminum must have caused the amyloid to form, but that is not the case. It's just the opposite. This
Okay.
amyloid protein is very sticky, so if aluminum has to be, if it's just passing by, so to speak, it gets pulled onto the amyloid like a magnet. So it's a chicken and the egg. But to answer your question, I know that was long and roundabout, but I want to make sure my answer was clear. No, there
Yeah.
really isn't any clear relationship between aluminum ingestion and Alzheimer's disease.
Okay. Are there, and we are going to take a break down at the bottom of the hour, but are there some other typical myths that are out there that are pretty common among your patients that you hear?
Yeah, one is that I think the vast majority of patients, I think that all cases of Alzheimer's disease are inherited, and
Mm,
they are not.
okay.
And once I tell patients that, they're often reassured. There are some genes that can increase the risk for Alzheimer's disease in one's lifetime over the age of 65, but because you have those genes does not necessarily mean that you will be affected by
Oh,
Alzheimer's disease. So the message there is that genes are not destiny.
okay. Well, that's uh, exciting to hear. I mean, you always most diseases we hear are hereditary, so that's kind of good news there. Any other common myths that you hear quite often?
Yeah, there's a
I'm sure
smattering.
you hear them all, don't you?
There's so many, but the one that I hear most often and the one that causes the greatest concern is the fear of the genetic risk.
Okay.
Another is, I hear very often head injury. I
Mm,
hit my head, so that's going to cause me to have Alzheimer's disease. Yeah, there is a slightly higher risk if you've had a serious concussive head injury or developing Alzheimer's in your lifetime, but
okay.
it doesn't mean that if you hit your head at some point in the past, you're definitely going to get Alzheimer's disease.
Okay. Okay. It's good. Um, and again, we're coming up on a break. This is Torn in Two, your news and information program. We're on with Dr. Kevin Foley talking about Alzheimer's and memory loss. Uh, Dr. Foley, take us back to kind of like the early history. When it was when we first started learning about Alzheimer's. We had probably had other names that we didn't know what to call it. But when did we first come up with this diagnosis of what Alzheimer's was?
Yeah, there is actually a Dr. Alzheimer for which the disease is named. He
Oh,
discovered the disease in the early 1900s.
okay.
He was born a German uh, born in Germany, in Bavaria. He
Hmm.
became a medical doctor and a psychiatrist, and he took great interest in neurological disorders. He met a woman when he was an attending physician in Frankfurt and followed her along until the time of her death and was able to get her brain to analyze. And he was the first to document the pathological changes associated with Alzheimer's disease, which was later called, in honor of him and his discovery, which is
Hmm.
the same as they have been over the last 100 years.
Okay.
And interestingly, when he presented his research, he was scoffed. His colleagues didn't think that this was a real entity, and
Okay.
they almost entirely dismissed it.
Wow.
60 years go by, and then there was a reinterest in this ailment and this disease and what it might represent and how to define it. In the modern era of Alzheimer's disease, research and acceptance has been since about the 1960s.
Okay.
And it's been called many things over the years. When I was a medical student, we didn't call dementia Alzheimer's disease if it were due to Alzheimer's. We called it organic brain syndrome.
Mm.
Sometimes it was called senility. We never use that term anymore because it's pejorative. It was
Okay.
called a lot of different things because we didn't have the actual diagnostic criteria that we needed to be accurate, and those came around in the 1970s. So over a
Okay.
long period of time, we have become more specific and more expert in calling it what it is and understanding how it happens, at least based on the basic science that's been done so far, and the targets that we need to look to and the further research that needs to be conducted so that we can do the best we can in
Okay.
taking care of those patients.
Okay. So, and I don't know if I asked you this, but so having Alzheimer's, is that can that be a cause of death, or is it other things that Alzheimer's leads to the total memory loss?
Yeah, that's a great question. Alzheimer's is considered the sixth most common death in the United States.
Oh, okay.
It by itself does not lead specifically to a person's demise, but renders them more susceptible to other problems, which then can cause their death. It is
Okay.
still, because of that, it is still recognized as a specific cause of death as far as death statistics, but it does not primarily cause death in most circumstances.
Okay.
Usually, if a person will live long enough, they will have an accident that may be life threatening or an infection.
Okay.
But by far and large, most people who have Alzheimer's disease who are older die of some other condition that's not related to their disease. Heart
Okay.
attacks, strokes.
Okay. And how did you get interested into this specific area, Doctor Foley?
Oh, that goes back a long, long time. uh, so this was back in the early 1990s. At the time, I was working at the Cleveland Clinic.
Okay.
I was a junior physician, so to speak, at the time, and my supervisor, my boss, was very adamant about expanding our clinical service lines, and he gave us all options.
Hmm.
And of the options that were presented, I said, "Oh, well, I'll develop a clinic for memory loss and dementia." And that's what started my interest. I had the opportunity to talk to other experts and learn more about how to do clinical assessments and how to treat it. And I was there for 5 years, and that got me started. So I moved around a couple times
Okay.
since I was at the Cleveland Clinic, ended up in Grand Rapids in the early 2000s. And when I settled here, I realized that there were no services, no clinical services at all for people who had memory
Mm.
loss or dementia,
Okay.
in a city that was almost a million in population.
Okay.
And having had the previous experience in working in memory disorders and seeing the need here, I decided on my own to schedule a meeting with the prior chief executive officer here at Trinity Health West Michigan at St. Mary's. And
Hmm.
I said, I see an opportunity for this hospital system
Okay.
to build a program that is not present anywhere in West Michigan.
Mm.
People from this
Yeah.
community were going to the Mayo Clinic in Minnesota or down to Ann
Okay.
Arbor. And I
Hmm.
said, this is not going to take very much to do. I have some expertise in getting it started. If you will support it, I will give my full commitment. And I've been here ever since.
Okay. And you introduced yourself as professor. You're currently teaching as well.
Yes, my primary employer is Michigan State University. I
Okay.
was here full time until 2008 and was invited to become a division head of geriatric medicine at Michigan State.
Okay.
But part of the contract was I told them that I would want to fulfill my clinical obligations here because I'd built this program
Mm-hmm.
that was very successful, and that if I left, I was concerned that it might not be as successful. So they were willing to let me do that. I've been commuting back and forth between East Lansing and Grand Rapids for a number of years,
Okay.
but the opportunities at Michigan State were tremendous. It's given me a chance to explore other areas that I'm interested in
Okay.
geriatrics education and healthcare workforce policy studies. So it gives me the best of both worlds. And
Okay.
it also adds a level of prestige, I think, to our program to know that I am affiliated with Michigan State. And it gives me the opportunity to work with other scientists at Michigan State who are interested in basic science aspects of Alzheimer's disease.
Okay. Am I correct in saying I think I've heard that even this whole area of geriatric medicine is one of the largest growing areas currently?
Oh, it's huge. The need is extraordinary. And
Mhm.
we're working on trying to strengthen the workforce and also teach non geriatrician physicians more about the tenets of geriatric medicine. It's going
Okay.
to take too long to develop all the geriatricians that we need in this country. So, what we're trying to do is to teach primary care physicians in internal medicine and family medicine and other subspecialties what they know, what they need to know in order to take optimal care of older adults.
Okay. And again, I know it's probably not a normal. If I see a regular internist, is there a certain point when I should be seeing a geriatric specialist, or again, as you say, is it for internal practitioners to learn more about that
Yeah,
area?
what we're trying to do is to educate them further so that they will feel more comfortable and
Mhm.
confident in taking care of older adults. Whether or
Yeah.
not you would need to see a geriatric medicine specialist would be based on whether or not you have a healthcare problem for which a geriatrician would be the best option for your ongoing care and management. And there are
Okay.
several different disorders or syndromes that geriatricians take care of that are
Okay.
common among older adults. Dementia is one,
Hmm.
falls is another, frailty is a third. And there are several other syndromes that geriatricians are probably best prepared to take care of and manage. And there are geriatric medicine services in Muskegon.
Okay. Yeah. Dr. Foley, I was doing the reading and research for today. One of the other diseases that I saw that I think affects memory loss was Parkinson's.
Yes.
Could you talk about that a little bit?
Yes, all neurodegenerative diseases cause memory loss, and there
Okay.
are a constellation of neurodegenerative diseases that are out there. Parkinson's, yes, absolutely. What's a
Okay.
little bit different, though, about Alzheimer's dementia and Parkinson's dementia is that the memory loss associated with Alzheimer's disease occurs early on
Hmm.
in the trajectory of Alzheimer's disease, whereas memory loss due to Parkinson's usually happens later.
Okay.
People will usually have very well established diagnoses of Parkinson's disease based on the slowing of their movements and the tremors that they develop well before they begin to have any changes in their memory. And
Okay.
that just speaks to the way that the disease starts and where it spreads in the brains of people who have Parkinson's disease.
Okay. I mean, you talked about some of those things that affect memory, like rest, sleep apnea. Are there some other things that maybe present themselves, maybe like memory loss or Alzheimer's that get misdiagnosed?
Yeah, I tell you, one that I see very often is hearing loss.
Mm,
I've had
okay.
lots of people who have come in to see me. You know, the person who's with them says they don't seem to be able to remember anything. You know, when I tell them something, it just doesn't stick. When I ask about it later, it's not there. And as it turns out, they just can't hear what's being said.
Oh, wow.
Many people who have hearing loss don't want to admit to it. Most people who have hearing loss wait nine years before they have it evaluated.
Wow.
So, and usually what happens is you get the head nodding or the
Uh-huh.
uh-huh. So the way that I can figure that out is I have a set of headphones like these with an
Uh-huh.
amplifier and I put them on their head and then I say, "Can you hear me now?" And then go through the memory assessment and they do well.
Wow, 9 years.
9 years.
Wow, that's and I can believe it, but that's, Wow, that's something.
That's a very simple thing that can be screened. That's the first thing I want to make sure when somebody says I have a memory problem. I say, can you hear what's being said?
Maybe it's intentional. They don't want to hear what's being said. Yeah.
Yeah, but yeah,
Yeah.
that's a simple one. Medications, there's a whole constellation of medications that can impact memory.
Okay.
Um, yeah, and during the COVID pandemic, I saw so many people who came in who felt that their memory was declining, who were just succumbing to the stress of the pandemic. But just suffice it to say that higher levels of stress for whatever reason can impact your memory.
Okay. I believe we have another comment on the screen here. It says,
Hmm.
does
The
stress
stress
play a role?
in the onset of Alzheimer's dementia,
Yes.
that is an up and coming area of research.
Okay.
And there was a study was done at the University of Wisconsin. It was about 2 years ago that really did clearly show that higher levels of stress in the African American population definitely increase the risk of cognitive impairment.
Mm,
So
okay.
yes, that is a significant concern and needs to be further explored and then means found to reduce those stressors. I know that's not simple, but that would be a risk factor that would be potentially modifiable.
Okay. Do we see some gender or race factors showing up in memory loss and
Yeah,
Alzheimer's?
yeah. African Americans have the highest risk of Alzheimer's disease in this country.
Oh, wow.
Their risk is
Okay.
twice that of white people.
Okay. I wasn't aware of that.
Yeah, no,
Okay.
it's a significant health concern, and
Okay.
there are still disparities in healthcare that we are working to overcome.
Sure.
Everyone should be treated equally and
Hmm.
equitably. There may be some genetic factors that increase the risk of Alzheimer's disease among African Americans as well,
Okay.
and then other specific risk factors, high blood pressure and diabetes. So
Okay.
yeah, that is a population that we absolutely need to be concentrating on, and that has been brought out by expert groups in the country, including the Center for Disease Control.
Okay. How about gender? Any differences there?
Yeah, women statistically have a higher risk of developing Alzheimer's disease than men,
Okay.
and that may be because they live longer. That still
Oh,
hasn't been completely explored.
okay.
Age is the most significant risk factor for developing dementia among all people. So,
Okay.
because women live longer, it may look like they have higher rates of having Alzheimer's disease, but there has not been any conclusive evidence to suggest that either men or women, because they are men or women, have a higher risk.
Okay. You talked about, the couple comes in and tell me, and the spouse says, "Hey, something's wrong with them." Talk about the role that family members play in a kind of a proactive way when they seem to notice something might be off.
Yeah, whenever I see somebody in my office, it is obligatory that someone come with them who knows
Okay.
them.
Okay.
For reasons you might expect. If
Sure.
somebody has memory loss, they might forget about some of the things they're forgetting.
Yeah. Yeah.
So we need to have another story to
Hmm.
listen to, and also to put the complaint into a context. I don't think that we as as individuals have a very good read on how we're doing.
Hmm.
If somebody were to ask me, are you okay? Are you getting things done? I would say absolutely so, but somebody else might not think that to be the case, like my wife. They have
Okay.
a different perception. So it's
Yes.
interesting. We need to hear that perception
Okay.
to get the story. And
Okay.
if a diagnosis of dementia is made, then we rely on that person. It might be a spouse, a child. We rely on them to be part of the care team. Because when you have Alzheimer's disease, you need help. You need
Yes.
others to
Yes.
be around to provide support and supervision. So we enlist the help of family members. So their role is important from the beginning, all through the process of how the disease progresses.
Okay. Dr. Foley, again, we're on the call today with Dr. Kevin Foley. We're getting some tremendous information about Alzheimer's, memory loss. So I hope that our listeners are taking this information in. Appreciating this conversation, Dr. Foley. For our listeners who are out there today, with most diagnoses, there's this idea of fear of going to the doctor and asking the question. Help us a little bit with just getting past that initial fear of, because we always think the worst, because we go to WebMD, and by the time we come in, we got 6 months to live. So help us get past that initial fear.
Uh, yeah, that's a prominent problem. I tell you, very commonly, I have someone who's already scoured the internet and diagnosed themselves before they see it. And many times they're not quite spot on.
You're being generous, aren't you?
Yeah, well, yeah. I know
Yeah.
firsthand that your mind can play games.
Yeah. Why go to medical school? We can just go to the internet, sure.
Right. And it's very easy to let your subconscious just take off and
Yeah.
then you to fear the worst.
Yes.
Not all memory loss is as a result of a dire, dreadful disease first. So
Hmm.
go into an appointment if you're referred with an even mind that you might come out with good news and not bad news. I give a lot of good news, and it's very refreshing for me to do that. If it is a diagnosis of dementia, which would be expected to progress over time, I try and provide some tidbits of information that provides some optimism, sort of a silver lining around the black cloud.
Hmm.
And that's based on what we understand the trajectory of memory loss to be in individuals and populations.
Okay.
There's just as much reason to believe that progression will be very slow and will not really impact that person's quality of life over time.
Okay.
As I mentioned before, the pace of research is going so quickly that new developments will be found. Another reason to be optimistic.
Okay.
And even if there is progression of symptoms, there's reasons to continue to work at maintaining quality of life.
Okay.
Memory is important, and we want to preserve our memory as much as possible, but there's much that a person with memory loss can do to feel like they have a sense of purpose and to go on in their lives. So those are the pieces of information that I provide to people who have diagnoses that we would expect would continue to get worse over time. But first and foremost, don't go into the appointment thinking you're going to get the worst news ever.
Okay.
I don't know how many times I have gotten to the point of providing a diagnosis. I can see the fear building up in the
Mm-hmm.
patient's eyes.
Mm-hmm.
Like he's going to tell me that it's bad.
Okay.
And I say, no, it's not. It's not.
Okay.
And there's the sense of relief that they feel
Okay.
in hearing that. But they shouldn't have felt that way. I guess I can understand why, but there's no reason to fear what you don't understand. Like Roosevelt said, all we have to fear is fear itself.
So,
So
I'm still,
don't fear your fear.
yeah, with the hearing loss to 9 years, that's still kind of resonating in my mind. So I'm thinking, with memory loss, how long does it go on before we even start to acknowledge it?
Yeah. Most of the studies that are in print suggest that it takes about 1 or 2 years for people with progressive memory loss symptoms to recognize that there's something wrong and to get evaluated.
Mm,
So,
okay.
my advice is if you are seeing changes and are concerned, don't dismiss that. Don't accept that those changes are due to aging.
Yeah.
Get it checked.
Yeah. Okay. Again, folks, we're on today with Dr. Kevin Foley. Um, Dr. Foley, I apologize. Tell folks who you're with again.
Right. I am with Trinity Health, West
Yes.
Michigan. I am
Yes.
located at the Howenstein Neuroscience Center at St. Mary's Hospital in Grand Rapids.
Yes. Thank you. So some of our listeners may have joined us late. Walk us through, and we talked about this earlier. Some folks join us at different times, but um, Dr. Foley, I'm listening to the show today. Yeah, I do notice, again, can't find my keys. I walk into the wrong room. I'm doing the finger snap and can't recall a few things. What's the first thing I need to do other than get a good night's sleep? What's the
Right.
what's the next thing I need to do?
Journaling, I think, is helpful. If anybody is
Okay.
really concerned, but not to the point where they say, I need to get checked out, then keeping some sort of a log, a calendar of the mishaps and the oversights that might be occurring and the frequency and the time of day, that would be very helpful. Because the first thing that I do when I sit down and introduce myself to a patient and their family, I say, tell me the story. And if you don't know the story, it's going to be hard for me to go farther.
Okay.
than the interview. So that's really important. The second is, if you have a close friend, confidant, spouse, parent, child, is ask them what they think. From time to time, I have patients that come in that are very concerned that they're losing their memory. And then I ask their spouse, well, what do you think?
Mm,
And they say, no, I think things have been about the same as they've always been,
okay.
which then creates a different set of clues in terms of formulating a possible explanation for that patient's complaint.
Okay. Okay. That's good. And, also which something you mentioned was the medications, which
Right.
I think is another important thing. We don't often, you know, I think sometimes we assume, well, if they gave it to me, it must be okay. Without necessarily, the pharmacist, hey, you got any questions? Oh no, I'm fine. So I think that's important that you kind of mention that to us a little bit.
It is. And I'll tell you, there's some very commonly taken medications that are out there over the counter that don't have any warnings at all about memory loss.
Wow.
The allergy medications and sleep aids,
Mm-hmm.
they
Yeah.
definitely can impact memory. But if you
Yeah.
read through the package insert, you're not going to find anything specific to that side effect.
Okay. Interesting. Yeah. Dr. Fuller, I know I'm sure you get interviewed and asked questions like this often. Anything that we haven't talked about today you think is important that we share with our listeners today?
Yeah, I think so. There is one other area, prevention.
Oh, yeah.
Yeah, there are some
Yes.
prevention strategies that are coming
Okay.
around, and our messaging about prevention has really changed a
Okay.
lot.
Okay.
As we used to tell people to change their diet, we talked about this before,
Mm-hmm.
change their diet, exercise, and do crossword puzzles to prevent memory loss.
Mm-hmm.
What we're finding now from research is that there are different strategies that may be more effective.
Okay.
Number one, if you have sleep apnea or at risk for sleep apnea, you need to get it checked out and treated, because there is a subset of patients who have sleep apnea that if they don't get it treated, that will definitely increase their risk of developing dementia.
Okay.
That's one. Two, medications. Long-term use of medications that have certain side effects. I'll just mention this. They're called anticholinergic side effects. They're common to sleep aids and other drugs. Long-term use of those medications may also be a specific risk factor for developing dementia over time.
Okay.
And then the third, we've talked about this already a couple times, hearing loss.
Mm-hmm.
Hearing loss can mimic a memory disorder, but there's some very new evidence that suggests that persistent hearing loss that is not treated also can increase the risk of developing dementia.
Okay.
So if you're interested in prevention, you can put your newspaper down and not worry about the crossword puzzles, but get your hearing checked. If you have sleep apnea, get that evaluated and have your primary care doctor look at your medications to see if they have those anticholinergic side effects.
Okay. Uh, Dr. Fuller, and we know we should start with our primary care physicians. Are there some other options available to us? Some folks don't have a primary care physician. Are there some other options people have if they have some concerns about their memory loss?
Yes. Yeah. I'm always willing to see anyone who has a memory complaint. And
Okay.
I rely on the primary care physicians, so to speak, to get the ball rolling.
Mm-hmm.
Occasionally, sometimes they do, many times they do, sometimes they don't. That's okay. I think what's most important is if somebody really has a concern that needs to be evaluated and can't wait for a primary care physician to schedule them, or they don't have one, then they should just be referred to a center like ours
Okay.
and have a comprehensive evaluation performed.
Okay. Well, again, it's been a tremendous 55 minutes here talking with Dr. Kevin Foley. Hopefully, you guys have been listening intently and taking notes like I have, and just generated all kind of thoughts and questions and things for me to kind of think about. Like a lot of people, I've watched my parents age.
Mhm.
So some of the things you talk about, I bring to my mind like things like hearing versus memory loss. My mother lived to 86 and tremendous memory, but she was one of those did the crossword puzzles. But I think you've kind of really been enlightened us quite a bit on this area today. Anything else, Dr. Foley, that we need to make sure we touch before we leave today?
Well, June is Brain Health Awareness and Alzheimer's Disease Month.
Oh, okay.
So it's a good time to put
Yes.
into practice some of the things that we talked about and think about brain health on a daily basis.
Okay. Now, when you say brain health, which sounds kind of tell us what during this month, if we want to say we want to focus on brain health, what kind of things can we do to
Sure.
help our brain?
Much of the strategy for maintaining one's brain are the things that I talked about,
Yeah.
and looking at
Yeah.
prevention strategies, but also if you have high blood pressure, make
Hmm.
sure that it's controlled. High blood pressure can increase the risk of certain types of strokes that can lead to memory loss.
Okay.
If you have diabetes, make sure your diabetic control is optimal. If
Okay.
you smoke, don't smoke. So, those are some of the simple strategies. Primary care physicians can absolutely talk to you about ways in which you can address each one of those concerns. And in that regard, that will lower your risk of developing certain types of memory loss.
Okay. Well, good. Well, this is a good month for folks to to stop, take a pause, think about their brain health, things they can do. So we have another question here. Does seafood help? Don't know if he mentioned it. Yeah, again, I think I've heard that before. Those seafood helps.
Possibly, fish is one of the main constituents of the Mediterranean diet,
Hmm.
and that has been opined to possibly be effective in preventing memory loss or slowing its progression.
Yeah.
So I'm not sure how seafood is defined. If it's fish that come out of a lake or out of the ocean, that's probably fine. If you're talking about lobster or shrimp, I'm not so sure.
Yeah, yeah. Doctor, is it one of those things? If it's not hurting you and you think it's helping you, that it's probably okay. Keep doing it. Is it kind of that thing?
Yeah, as I said, I never dissuade anyone from adopting a healthy lifestyle in whatever way they think that what they're doing is healthy,
Okay.
provided that it is healthy. Because we don't have all the answers. There's still a great deal of research to be done. If
Hmm.
somebody is inclined to change their diet, I'm not going to tell them it's not going to go against them. I just don't know whether or not it's going to make a difference. It might. Exercise, I recommend that to everybody. Everybody needs to
Yeah.
exercise. You need to avoid bad habits. There's nothing good about smoking.
Yeah. Eating healthy, exercise. Those are you guys always lead with that, Doctor Foley. It's like,
Right. That's how you
yeah,
maintain your brain and all the other organs that are attached, below your brain.
yes, that's good stuff. Dr. Foley, before we wrap up here, anything else you want to share with the audience? We thank you just so much for being here and spending this time with
Yeah.
us.
Just know that our healthcare organization is always available and willing to see patients and to address their concerns, both related to memory and other healthcare conditions.
Okay.
We appreciate your taking interest in this topic, and any questions that might come up after the fact, people can contact us at our healthcare organization at Trinity Health West Michigan in Grand Rapids.
Okay.
We're very proactive. So just know that we are available and interested in your health and your welfare.
Okay. Dr. Foley, thank you so much again for joining us today. We appreciate it. We appreciate you informing and educating our audience today.
Well, thank you very much for having me on the program. And I would be willing to come back and extend our conversation at any time.
Well, appreciate that very much. Well, folks, again, this has been your Torn in Two broadcast today. I hope that you have gained something from Dr. Foley today in our discussion. As my good friend and brother Greg T would say, this is a beautiful weekend here in West Michigan. You should probably go out, get some exercise, get some fresh air, get some good rest, uh, be kind to other people, and do something nice with somebody else. Take care and be blessed. All right. Thank you, Dr.